Assalamu alaikum. This is Muhammad Mahir, and I'm gonna try to explain to you guys all about the adrenal gland, or as some other people say, the suprarenal gland. It's basically the same thing. This video will cover mostly the anatomy, physiology, pathology, and even the histology of everything about the adrenal gland. That being said, this may or may not cover everything about the adrenal gland, so you have to, I guess, go back to the sheets on about the adrenal glands and study that as well. So treat this video as some sort of like, I guess, a revision overview, or even like something that you would watch before the exam that is coming, inshallah. So yeah, let's start. So basically, yeah, let's talk first about the anatomy of the suprarenal gland or the adrenal gland. It lies literally above the kidneys, right? This is like the position of the adrenal gland. It's basically in the name, like suprarenal. Supra means like above the renal, or like the kidney or the renal system, and it's also a gland. It uses like multiple hormones like epinephrine or epinephrine 6, steroids, cortisol, aldosterone, uh, a lot of things, a lot of like other things like subdivides. Uh, let's dive deeper into the anatomy here a little bit and see. It's mainly like the position here. The right one is like uh, inferior to the liver. Liver should be something like this. It lies literally under it, and so the adrenal gland has uh, basically like multiple layers. We're gonna talk about them later on, like on this page or video, I guess. But let's talk about the blood supply here. So we have, uh, uh, in terms of the arteries here, we've got the middle adrenal artery, and then the inferior adrenal artery, or the superior adrenal artery, which is a branch of the inferior pharynx artery here. And yeah, that's very much it in terms of like the arterial supply here. Uh, about the drainage, we also have mainly one vein here. It's called the adrenal vein. Simple as that. It's basically that simple. So we got like three supplies here: superior adrenal artery, middle adrenal artery, and inferior adrenal artery, right? Uh, they all supply the adrenal gland. Uh, they might ask you like a question on the exam or whatever about the branches that comes off the supplies is the adrenal gland. You would say something like, "Oh, the inferior adrenal artery comes from the renal artery, and the renal artery is part of the aorta, like the abdominal aorta, or like a branch of it, I should say." And the middle adrenal artery comes from the abdominal artery, and the superior adrenal artery is a branch of the inferior pharynx artery, or whatever it's called, I guess. Uh, Sorry if I do pronounce some stuff wrong. I'm gonna try my best because, well, I'm not an English person. But anyways, that's basically it in terms of the blood supply, and for the vein as well. It's just like a branch. The adrenal vein is just a branch of the vena cava here. And so about the physiology and also the histology of the adrenal gland. So let's say, for example, we'll just like cut off like part of like uh, we just cut off the adrenal gland in half, just like that, and we see like a cross section. uh, it's like the adrenal gland is like something like this, right? We have a cortex, it's right here, like, and we have a medulla. So if you remember the renal system, the word medulla, oh, like these are like the medullas of the kidneys, right? It's basically the same thing, but it's also the in the adrenal gland, and there is also the cortex. Also, there is like a cortex in the kidney as well. So basically, we have an adrenal gland. I'm sorry, the medulla here and the cortex. The cortex literally lies over here, right? And so um, the medulla here is important because it produces epinephrine or norepinephrine. So, what is epinephrine and norepinephrine? So, epinephrine is basically like literally adrenaline and noradrenaline. So it produces epinephrine and norepinephrine. And what this does is it's important for fight or flight response. However, it only like works for like a short amount of time. It's like not long period amount of time, this type of thing, and it's produced by the sympathetic nerve and parasympathetic nerve. So it's the only part of the adrenal gland that is like produces, I guess, the produces the hormones epinephrine, norepinephrine by a nerve, and only a nerve. And so we got also the cortex, which doesn't get stimulated by a nerve. However, it does get stimulated by hormones. And we're gonna talk about those hormones in a second. But for now, let's just like imagine a scenario here where you're getting like chased, I guess, by I don't know, like multiple dogs or something like that, and you're just trying to like run away, right? In this situation, your adrenal gland, or I guess your brain, is gonna like stimulate your suprarenal gland or adrenal gland to produce epinephrine and norepinephrine throughout the sympathetic nerve, right? And so when you get to safety, it's gonna like symbiotize work on the sympathetic system to produce non-epinephrine, which is like the inhibitor of epinephrine. And so the problem with epinephrine is that it's not a steroid. It's like a normal hormone type of thing, and it's just like it doesn't stay for too long. That's the problem with it. But imagine another scenario where you're basically putting yourself through, let's say, like you have like an exam tomorrow, and so naturally you would be like stressed, right? Because let's say you didn't study anything for the exam, and it's just like you would be like stressing so much. And so the epinephrine and norepinephrine, like your brain can't just like keep asking the adrenal gland, hey, produce more epinephrine and more epinephrine so it can, like stimulate the stress of the body, even though like the body can it only like lasts for a short amount of time. And so uh, this is comes when like at this point the body can't just like keep doing the sympathetic nerve thing on the adrenal gland, so it's gonna start working on the adrenal cortex here. So the adrenal cortex is mainly important for um, basically the long-term stress type of thing. uh, as we said, back to the scenario, we're going through like a lot of stress, right? And so for like your body would naturally like produce these hormones, mainly cortisol actually, but it comes from like the cortex of the adrenal gland for the long periods of time type of hormones that makes you stressed for too long. And so these hormones are basically androgens or sex steroids, cortisol, and uh, and aldosterone. Sorry about that, aldosterone. So yeah, that's basically like the main three hormones. Those comes from three layers of the adrenal cortex. We call them the zona fasciculata. Sorry, the zona radicularis, the zona fasciculata, and zona granulosa. So the granulosa is like the most outer layer here, and the fasciculata is right here, and it's like the biggest layer of them all of the cortex. And radicularis is right here. I think it's like the smallest one of them. So like I remember like uh, a question on the exam that asked about which of the following. I think it was like a spotter exam here. It said something like which of the following um, layers are the biggest, or something along those lines. Or maybe I showed like an image of the I guess the adrenal gland, like histology or whatever, specifically the cortex, and it showed like these layers. It showed like, hey, which of the following are uh, the fasciculata, like zona fasciculata layer here, and basically like it naturally would choose like the biggest layer, right? Because you can see it's visibly bigger and thicker than the other layers, and so you would naturally like choose it. And but I do advise though watching like some images from Google about these type of layers, like in histology, like images or whatever. uh, but yeah, that's like your own thing. You can do it by yourself. Coming back to this, so basically, uh, granulosa, granulosa. If you can't memorize it, an easy way to memorize it, the word granulosa comes from granulus. If you remember the word granulus from the adrenal gland, the adrenal gland. No, I'm sorry. Sorry, the kidney from the nephron. It has part of the nephron is called uh, the gramulus. It's called the gramulus, so we can memorize it with that type of thing, I guess. Gramulosa, zona gramulosa here. Uh, the word radicularis, zona radicularis, reticularis here. It's called reticularis. I guess you could memorize it from the word ridiculous. Like it's just the word ridiculous here, right? And I can't. Unfortunately, I can't find uh, a close word to the word fasciculata here. So you have to memorize it. Another way to memorize like the patterns is GFR. GFR. If you remember the renal again, the renal system, GFR is like the uh, sorry, GFR is like the uh, it's a measurement. I can't exactly remember what type of measurement it is. I think it's like uh, uh, granular filtration rate. The adrenal gland also has this on its layer called the GFR, except it's granulosa fasciculata reticularis. All right, so yeah, epinephrine and norepinephrine, fight or flight response for short amount of time. Short. Those are for long amount of times. This one is for from comes from the medulla, and it's stimulated by the sympathetic nerve. And so the other one is like comes from the adrenal cortex. It's produces sex steroids, reproduction, obviously, cortisol, uh, stress signal for a long period of time, aldosterone, which is important for HTOR reduction or whatever. So let's dive deeper into the physiology of the adrenal gland here. So the medulla releases epinephrine, norepinephrine to stimulate uh, uh, as a short hormone during stress, while the adrenal cortex is mainly for long-term stress sections here. Yeah, we already talked about this. So basically, this is the adrenal gland histology here. Obviously, as we said, the sympathetic and parasympathetic from the brain stimulates the medulla here, and the other layers here would be ricularis, fasciculata, and granulosa. So basically, what stimulates these hormones are mainly ACTH. ACTH here means adrenal uh, cortical releasing hormone, something like this, I guess. Basically, like the important part is that it comes from the anterior pituitary gland, which is this thing here. No, this thing, not the other one. Uh, and what stimulates the ACTH is CRH, which comes from the hypothalamus, right? So the hypothalamus here releases CRH, which is a cortical releasing hormone, and that hormone stimulates ACTH, and ACTH stimulates all three of the cortex layer, right? And another thing would be you, I guess, stimulate cortisol. I mean the sorry the granulosa here would be the ad, angiotensin, sorry, angiotensin too, and high levels of kalemia, hyperkalemia, and uh, uh, this thing again. Sorry, I can't pronounce it. I just forget so fast. Those two, along with ACTH, can stimulate the granulosa to produce aldosterone here. Obviously, aldosterone is like important for, like, as we said, H2O management. And okay, so uh, that's pretty much it. The ACTH mainly affects. I say mainly. This is why I kind of like put it in like a thick um, arrow here. It mainly like uh, stimulates the fasciculata to produce cortisol here, but it has an effect, but it's just like a small effect on the reticularis for the sex steroids here. Um, so basically, the ACTH, back to here, I guess. ACTH comes to the zona fasciculata to reduce cortisol, right? Cortisol is a steroid, and so it needs a carrier, right? It needs a carrier, but those carriers are like, they exist obviously because the it's a steroid, and it can easily bind into like a lot of things, so it needs to have a carrier, so it's like it doesn't go get through like the what do you call it, the the arterial walls, because it's just like that small. And so um, it needs a carriers obviously, but when there is like a free cortisol, then it means there is higher than average levels of cortisol here, which is a problem. Why is that? Because you don't want to have like uh, high levels of cortisol. This is literally like Cushing syndrome here. And so what your body does here, it kind of just manages this levels by just basically like the free cortisol here travels into the hypothalamus and stimulate it and makes like some sort of like negative feedback here. And that's this negative feedback is important because it asks the hypothalamus says, "Hey, stop producing CRH." And so the hypothalamus goes like, "Oh, okay, I'm gonna stop then." So it stops, and the CRH is suddenly dropped. And when you have low CRH, then you have low ACTH, and when you have low ACTH, then you don't the zona fasciculata doesn't produce as much cortisol. And so this is how it's managed. Like it doesn't like go above or below a certain percentage. I think it's mainly like 5% of the body. I can't exactly remember that one. Sorry about that. But you get the idea here. So, sorry, the granulosa, as we said, high levels of kalemia and uh, high levels of angiotensin 2 makes a positive feedback to the granulosa to produce aldosterone. And aldosterone helps with reabsorption of sodium. Okay, why is this important? Well, let me tell you something. Um, so basically, aldosterone, if you remember the renal system, aldosterone helps with the reabsorption of sodium, but at what cost? The potassium here. It's kind of like it trades. So basically, you have like this wall, right? And so this is like the wall of the nephron. When aldosterone comes, it takes like you have like too much uh, potassium on the blood, and there is like sodium here, right? And what it does is it takes this sodium inside the blood, and in trade-off, it lets in the potassium in the urine or the internephron, so it can be released, right? And this is basically how it works. It kind of like it trades like a cross-sectional absorption or whatever. Uh, so it kind of like manages the potassium for the sodium. So this is why when people have too much aldosterone or hyperaldosteronemia or whatever it's called, I guess, um, they mainly have like hypertension from all the sodium, hypernatremia, and hypokalemia because of all of this. Um, Also, high levels of angiotensin 2 can also cause this. Can also cause hypernatremia and hypokalemia. And we're gonna talk about the treatment of those later on. Sorry, sorry about that. Someone was calling me. Okay, so as we said, we're gonna talk about the treatment later on. And radicularis here. So we're gonna talk about the radicularis here. Obviously, it's stimulated by ACTH. And so ACTH, uh, positive feedback here, makes uh, androgens, which is basically the sex steroids. Sex steroids could be something like, I guess, testosterone, I guess, which is present, believe it or not, in male and female. Uh, yeah, this is also important. The medulla is the only gland that produces hormones by the nerve. So you would ask me, hey, where did the angiotensin 2 come from? Well, the kidney doesn't only have like one function here. I mean, yeah, its main function is like I guess, filter the blood, right? But it can also produce renin, which is by another function. I think it's like mainly by the lung or something like that. I'm not sure exactly, but it somehow the kidney produces renin, right? And then turns into angiotensin 2. Angiotensin 2, as we said, stimulates the zona granulosa to produce aldosterone. All right, so that was that's pretty much it about the physiology here, I guess. We might just talk about it a little bit more on the pathology here, but let's start with Cushing syndrome. So, pathology here, obviously. What is Cushing syndrome? Cushing syndrome is an endocrine disorder with uh, elevated levels of cortisol in the blood. So, you have like high levels of cortisol, right? Why is that? Like, let's go back here. Why would you have high levels of cortisol in your blood? This thing here. It could be something like, an adenoma, or even like something like a carcinoma in your anterior pituitary gland, or maybe like there is like a dysfunction in the hypothalamus that produces too much CRH, or even like something like adenoma, or even like a carcinoma in the adrenal gland itself that produces too much cortisol. So that's like the main idea here. So normally cortisol levels in the blood does not go above 5%. We're talking about the free cortisol here. This free cortisol is moving, doesn't like the one that isn't bind with the cortisol binding globulin. Um, the 5% here of the total plasma makes 5% of the total plasma. When it does it, so and when it does it triggers so basically when it goes above 5%, it kind of like triggers a negative feedback telling the hypothalamus to stop producing uh, ACTH, I mean CRH to the ACTH to cortisol, I guess, in the adrenal gland. You get the idea here, you get the story. So cortisol is like a very important hormone here, and so when you have like too much of it, it can cause problems, like a lot of problems. How is that? uh well, basically it can cause high levels of cortisol can cause gluconeogenesis. So gluconeogenesis basically means glucose breakdown. You're basically breaking down the glucose here, right? Breaking down the glucose uh, would increase the level of glucose in the blood, right? Which naturally gonna turn into hyperglycemia. It also increases the level of protolase, which is basically a protein breakdown. It basically like breaks down your muscles, and it increases the lipolylase or whatever it's called, which is breakdown of fat. So you would like have like some sort of like patient that would have like central obesity, I believe, uh, but it's also losing weight in their arms because they're losing their mother their what do you call it, the muscle mass, and they would present with like hypertension. So what would cause the high cortisol? As we said, could be anterior pituitary gland adenoma or carcinoma. That's actually it's kind of like rare to have like a carcinoma on the adrenal pituitary. Sorry, I mean the pituitary gland. It does happen. Could be like an adenoma or a carcinoma in the adrenal gland, or could even be something as like a medication it could be like something like I guess medication for like cortisol levels when you have like someone that I guess takes too much cortisol and it kind of just like overdoses on that. It triggers high levels of cortisol and could cause high glucose levels, hyperglycemia, which could make high insulin, and high insulin makes activation of lipoprotein lipase. Uh, so basically, what happened is, so yeah, naturally, your body when your beta cells, which basically the cells that produces insulin, finds out about high levels of insulin. Uh, glucose here. It kind of like just triggers a response where it produces insulin, so it can like manages the glucose level in the body. And the problem here is insulin kind of like triggers uh, uh, the buildup of glycogen, which is basically like this like glucose, but like in a small portion is like stored in your body, in your kidney. And so when your kidney is sorry, not your kidney, your liver. And so when your liver is like full of glycogen, your body can't store it anymore. This is why it's stored as fat. And fat, when it's stored, this is why when you have like someone with like high cortisol levels, they would have like a central obesity. This is literally what I'm calling it right now. So basically, too much glucose means too much insulin means too much uh, uh, fat, I guess, storation, and obesity, more fat and obesity, and causes central obesity. So why central obesity? Well, it's mainly because the most fat is like of like glucose fat is mainly stored in the central part of the abdomen or whatever, and like the important part about it is the fact that someone would have like a fat I guess torso, but a very thin arms because obviously, as we said, it breaks down the muscles here, right? And another thing is severe breakdown of the bones could even cause something like rickets and easy, I guess, uh, easy fracture of the bones, smaller muscles, and even, I guess, uh, skin bros, or like you would like they would lose. People with like Cushing syndrome would like lose their skin or whatever, and yeah, easy skin bruising, as I said, bone fracture, and thin and weak muscle. Uh, it also triggers hypertension. Why is that? Because it increases the effect of catecholamines on the blood vessels. Sorry, uh, cross relation with the mitochondria receptors. That's for you guys to like read, I guess. Uh, so hypertension causes cardiovascular diseases. Obviously, too much uh, too much pressure in your blood can cause like something like a rupture or like even other complication, other heart complication. We're gonna not gonna talk about that right now. Okay, so this is everything, or at least mostly everything about the Cushing syndrome. If you need any questions about it, or even about everything from the previous one, just ask me. So Addison's disease. What is Addison disease? Addison disease basically when you have low levels of uh, cortex hormones that comes. Obviously, we know like the cortex hormone. We already talked about it. The cortex hormones here produces uh, these hormones, and when you have Addison disease, it basically means you have low levels of uh, hormones that comes from the cortex here. So you would have like low aldosterone, which basically hyperkalemia and hyponatremia, which causes like hypovolemia. I guess it also causes hypovolemia for like a reason, uh, which is like there's like low levels of I guess water in your body or like fluid. Why, you may ask? Because naturally here, um, sodium kind of like creates some sort of uh, I guess water kind of like follows sodium. That's like a rule everyone knows. So sodium grabs water with it, H2O, whenever it goes. So when the sodium is present, or there's too much sodium present in the nephron, it's gonna grab water with it, right? And so that's just gonna cause hypovolemia. And hypovolemia can also cause acidosis. So it could even like develop into renal failure, which is, I guess that's a thing. Low levels of cortisol can cause hypoglycemia, weakness, darkness of the skin. That's like another cause of like Addison disease. You would have like a patient with like a darker skin for some reason. Uh, like I don't exactly know the physiology behind that, but or I should say I cannot remember. Regardless, though, they would have like darker skin, and so when you see like an image of that, maybe you just like assume that they would have Addison disease. Also weakness, obviously. Low levels are for androgens. So androgens, as we said, uh, is basically sex steroids. What are the sex steroids? So low levels of testosterone, like testosterone here. So testosterone, as we said, it's present in men and women, right? And so it's like it would like sounds weird for someone from like the like an outsider or whatever for a woman to have like testosterone, but it's actually really important. Why? We're gonna talk about it right now. So men aren't affected by low levels of testosterone from the adrenal gland. Why is that? It's because they have their testes, right? Testes produces like 90% of their testosterone here, which is uh, more than enough for the body. Heck, even if the body doesn't like uh, doesn't get enough, the testes could even get enlarged so it can meet the body's needs of testosterone or whatever. Uh, so it doesn't affect the men in terms of like low levels of testosterone from the adrenal gland here. And so for the women, it's a big issue here. Why is that? Because it's important for the sex drive. Uh, so you would have like the woman doesn't like have interest in like sex or whatever with their partner. Less pubic hair and less armpit hair. What is armpit? It's basically the axillary hair. The the hair is like under your axillary or whatever. Um, yeah, that's basically for the sex steroids here. And the medulla here of the adrenal gland is not affected because, as we said, it's stimulated by a nerve, not by hormones. And so it's not obviously affected here. So, assuming there is like a damage in the adrenal gland, what kind of damage? Could be like something like an autoimmune response, could be a pathogen like TB, could be something like uh, metastastic carcinoma is like I guess there is be like a cancer that happened in like in an organ, but it kind of like spread through the blood and it reached the adrenal gland and kind of like done some damage here on the adrenal gland. And so something important about the adrenal gland here, uh, it's asymptomatic for like the first stages of it, about the Addison disease. Why is that? Well, we could like literally take a portion of like the adrenal gland cortex here, and it would just like meet the body's needs, like all the body's needs of the adrenal gland. And and so this is like a problem here. Why is that? Because like most of the time when people come with Addison disease, their the adrenal gland here is like basically gone. It's like there's only like less than 10% of the adrenal gland that is functional. Uh, and so here, as we said, when the adrenal gland is damaged, usually only shows symptoms when 90% of all the tissue is destroyed or necrotic, become necrotic or whatever. But why? Because only a small chunk of the adrenal gland can meet the body's needs. Yeah, so this is important for like a clinical thing, or like I guess or whatever, like it's something like this. And yeah, that's pretty much it about the Addison disease. And I guess everything else. If you have any question, please don't hesitate to ask me. I'm gonna try to explain everything later on. If you don't understand it, maybe like the other glands or whatever. Just remember that these type of diseases do have like a lot of questions on the exams that I do remember. One of them I remember was like something like, I guess, which of the following, what, like there was like I guess a 22-year-old woman that had like central obesity and low body mass, this and that, I guess. From like these symptoms, you would assume that she had like uh, crushing syndrome, but that's not what the question said. It would say like something like, which of the following should be the most appropriate action? Uh, the answer for that is to check for the I guess uh, the the cortisol levels and the urine, because if you don't know that, when you have too much cortisol, it ends up being released into the urine, and so this is how you diagnose it. Obviously, a treatment with that is to stop the medications, remove the adrenal adenoma or carcinoma, or like even like manage, I guess, surgically remove the adenoma of the anterior pituitary gland. Those are like the treatments of the Cushing syndrome here. And another thing would be, uh, yeah, you have like damage in the adrenal gland here, pathogen. You could also like, you need to stop obviously the pathogen here, treat the cancer, everything else, and I guess the treatment for the Addison disease would be like medications that meets the body's needs, something like, uh, aldosterone, cortisol pills, aldosterone pills, and even like anti even testosterone for the females if they need them, like testosterone pills or whatever. Like I don't know, I'm not like a pharmacist type of. I didn't say the pharma, I guess. But yeah, that's pretty much it. I hope you guys got the full idea and context here. Sorry if I do sound a bit, um, I guess, not clear for those who doesn't understand English. I'm trying my best here to like spread the message, because I know that there are people that don't understand the Arabic language here. Like people from Niger or whatever. But yeah, have a good one.